Hello, and welcome to the Dacera Clinical Education Oncology podcast. I'm your host, Ryan Topping. Today's episode features Dr. Ciro Rinaldi from the United Lincolnshire Teaching Hospital in Lincoln, United Kingdom, and Dr. Alessandro Vannucchi from the University of Florence in Florence, Italy, as they discuss contemporary topics in diagnosing essential thrombocythemia and polycythemia vera. This episode is part of a larger educational program titled Virtual Skills Lab in ET and PV, Bridging Diagnostic Gaps, Advancing Prognosis, and Preparing for Emerging Therapies. For more information, along with a link to the larger education program, please visit the show notes for this episode. Now, let's get started and hear what our experts have to say about this important topic.
My name is Alessandro Vannucchi. I'm professor of Hematology at the Careggi Hospital and the University of Florence in Italy. And I'm here together with Professor Ciro Rinaldi from the United Lincolnshire Teaching Hospital and University of Lincoln to discuss about contemporary diagnosis of patients with PV and ET. Ciro, welcome and thanks for your contribution to this discussion. So we know that we have two recent classification systems for patients with MPNs, with myeloproliferative neoplasms. And these are from the WHO, this is the 5th edition, and from the International Consensus Conference. So beyond the reasons why we have two contemporary classifications of hematological neoplasms, what is relevant for this discussion is that the diagnostic criteria for making a diagnosis of PV and ET are essentially the same in the two classifications. And this is, of course, good for us as clinicians in order to address the different aspects for reaching a correct diagnosis. In these classifications, in both classifications, there is a significant role for bone marrow biopsy. And Ciro, why do you think it is extremely important to have bone marrow biopsy for all patients where we want to reach a correct diagnosis of PV and also of ET?
Thank you, Alessandro. This is a very good point. I think it's, despite all the molecular, evolution of MPNs, I think we still rely quite a lot on morphology. I believe for two reasons. If you think about essential thrombocythemia, we don't have a other way to identify, prefibrotic myelofibrosis, for example. Some patients present exactly in the same way. So if you look at accidental finding of, thrombocytosis, it's really, really difficult without seeing the patients, without understanding the clinical picture, to be able to say, this is a true ET or it could be a prefibrotic. So there is a requirement to understand what the bone marrow look like, to perhaps give that confirmation. PV is another one. We have quite often, and I can see this in my center very regularly, accidental finding of erythrocytosis. And some of those patients, might either mask a different type of MPN because there could be a potential of overlap with some other condition. But for example, they might not show an increase in hematocrit and present with an anomaly such as an unexplained thrombosis, and the blood picture is not convincing. So those patients, I think, benefit from an histological evaluation because you're not going to be able to classify them otherwise. And that has an impact, not just to give the diagnosis correctly, but also how we prognosticate those patients. What is the type of follow-up, management, treatment, etc. So I still feel that is the reason why bone marrow biopsy is required. But I do see a problem here, and I will, ask back to you what you think. There is also a need for expertise in evaluation of those bone marrow, because, hemohistopathologists could be dedicated hemohistopathologists to MPN, so they have their own ability to recognize those subtle changes. But there are a lot of non-hemohistopathologists, MPN experts, where you still might have a problem and a gap. So, whether or not there is a further requirement to centralizing some of those review, that's, I guess, what I was going to ask you back.
You are right. This is a painful note because, unfortunately, the number of expert hemopathologists, and I would say particularly of young hemopathologists, is really decreasing in our countries. We are facing the same issues in Italy. So I think that, of course, the revised classification helps a lot because there are very strict criteria that have been described in this classification for attributing one picture to one disease rather than the other. But of course, experience is mandatory. And there's really need of sharing expertise, and this may happen in different way. In these times, maybe that we might be also helped by artificial intelligence, by the easiest way to share slides through the web. And these are all actions that even smaller centers might start to do with centers of reference. But you are right that in some cases, the same slide could be sent for review and for confirmation to a reference center. This is something that we do also in our institution, where we have some experience, I'd say, over the years for making this kind of diagnosis. But in some cases, we still another idea, another look to the same bone marrow biopsy. Of course, we now can take a great advantage of molecular biology, as you mentioned, because we know that polycythemia vera is in 99% of cases, I would say, characterized by the presence of a mutation in JAK2, that is 95-97% JAK2 V617F, and in the other 2-3% other mutations in exon 12. So this helps a lot in distinguishing particularly early cases of polycythemia vera, even with very low variant allele frequency of the mutations, from reactive erythrocytosis. The same help we can have in ET, because we know that 60% of patients with ET are JAK2 mutated, about 20% are mutated in carreticulin, and about 5% are mutated in MPL. So overall, 90% of patients with ET have a driver mutation. However, there is still a 10% of patients with a picture of essential thrombocythemia who do not have a mutation. These are called triple negative. And here it's sometimes difficult to assess if this is really a myeloproliferative neoplasm rather than another form of thrombocytosis, for example, familial forms of thrombocytosis. And this is something that should be very careful asked to the patient and the relatives. And in other cases, we still need evidence of a molecular abnormality, maybe a non-driver mutation, a mutation in TEC2, ACXL1, and so on, or, but this is quite rare, a cytogenetic abnormality to establish the clonal nature of thrombocytosis. Even these are tests that are not usually performed in smaller centers, but are performed in reference centers over our countries. And here again, there is the need to send these samples to these reference centers to establish in a very safe way the correct diagnosis of ET. And you also mentioned the fact that in some cases, the diagnosis happens by chance when you see a patient with a thrombosis, particularly, say, an unusual vein thrombosis. Is something that you would like to explore a little bit more, Ciro?
Yeah, so I think it's a very, very good point, and it probably link into anomalies that I was talking about. When we want to suspect that there is an MPN, I think in an unexplained clot, particularly in an unexplained vein, is often suspicious. If we have a splanchnic thrombosis, and it could be a splenic thrombosis, a portal thrombosis, a mesenteric vein thrombosis, those are not frequent DVTs. This is not a clot that we normally see in patients unless there is an additional complication, in some cases of liver disease or septic patient, etc. So for me, those needs to be investigated. And we know that MPNs, and particularly MPNs driven by JAK2 mutations, can clot the blood in unexplained places. So my suggestion for clinicians that are not necessarily hematologists or clinicians that are not necessarily experts in MPN is that if you do see a thrombosis affecting the splanchnic circulation, you probably want to request a JAK2 mutation, and perhaps you want to refer to an hematologist for further assessment. It's more common to develop this type of clot in this setting than in any other form of thrombophilia. And even in centers that look at coagulation specifically, they would probably request a JAK2. So I think this is an important one. The other one that I would probably want to expand a little bit on is some arterial complications that we see in young patients that are not explained. If you do develop a stroke when you shouldn't have developed a stroke because you don't have cardiovascular risk factors or even cardiac events, I think there is space there to perhaps consider some of those, because we've seen some of the ET patients presenting with some abnormal presentations with TIA where they shouldn't have had TIAs, or even a full set stroke damage. And I think again in unexpected presentation, I think we need to think about that. Some of those patients might have normal blood count, but actually in some cases, if you go back, you can see a persistent thrombocytosis that it wasn't picked up, because the way that some of those patients might behave is obviously very asymptomatic up until there is an event. So they don't go to their general practitioner, or if they do, they go very infrequently. So it's difficult to sometimes pick up a pattern. And sometimes some levels of thrombocytosis are not that concerning. And this is another message I really wanted to sort of share, and perhaps as a pearls for other practitioner. I think any level that persists, that is higher than a 450 mark for platelets, requires some attention. And I'm not sure that currently everybody do that. I think we tend to see patients much later on, and I guess this depends on what country you are and what kind of region. So I'm quite strong about that. And I think in the UK, for example, is even a criteria for unexplained cancer pathways if you have a persistent thrombocytosis, because it could represent a beginning of an MPN. So those were the points, I think, Alessandro, that I wanted to touch on. If you do develop an unexplained vein thrombosis, there is a requirement for further investigation. If there is a early set of arterial complication in patients where you wouldn't expect, I think there is some space there for investigation. And then looking at the blood results for a full blood count, if you have a persistent thrombocytosis or erythrocytosis that is not explained by inflammation or COPD or other reactive trigger, requires some attention.
So this is very important, because of course, making, especially in case of splanchnic vein or cerebral sinus vein thrombosis, this changes the therapeutic approach to the patient, because if this thrombosis, as happens in more than 60%, 70% of splanchnic vein thrombosis, of Chiari syndrome, or of portal thrombosis and so on, this implies that the patient requires lifelong anticoagulation. That would not be the case, for example, if the reason, the cause of thrombosis is a different one. So just to summarize what we have been discussing, in case of a patient who has abnormalities in blood values that are suggested for PV and ET, we have to go very in deep for the diagnosis, because we have molecular criteria, we have histopathological criteria, we have a lot of additional consideration, for example, exclusion, as you mentioned, of hidden cancer, exclusion of inflammation in the few cases that are negative for mutations, for driver mutations. But it's very important to get a precise diagnosis, including bone marrow biopsy, for all cases, because these patients require correct diagnosis, correct prognostication, and correct treatment in order to prevent the recurrence of thrombosis, and in order to correctly follow up the patients, especially since these are very long disorders over the life of an individual and are subjected to the risk of transformation to post-PV, post-ET myelofibrosis, and also, luckily enough, quite rarely, to a blast phase, to an acute leukemia. Thank you, Ciro, for your useful insights.
Thank you very much.
Thank you, Dr. Rinaldi and Dr. Vannucchi, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Virtual Skills Lab in ET and PV, Bridging Diagnostic Gaps, Advancing Prognosis, and Preparing for Emerging Therapies, please click the link in the show notes. And be sure to check back regularly for more episodes on important DSERA clinical education oncology podcast topics.